Okay, good afternoon, everyone. Welcome to Clinical Toxinology. Is it relevant to medical students? This webinar is now at Season 4, Episode 3, under the supervision of Prof. Khaldun. What a long way we've come. My name is Ming Hui.
And I'm Ting.
So we'll be your moderators for this afternoon. This webinar is organized by the Department of Emergency Medicine of Hospital Chancellor Tuanku Mukhris. For your information, we also collaborated with several esteemed organizations and to ensure this webinar success, namely Remote Evaluation Consultant Service, REX, Malaysia Society of Toxinology, College of Emergency Physicians, Special Interest Group in Toxinology, College of Malaysia Biodiversity Information System, National Poison Center of University Science Malaysia, and ToxEd. So before we begin, here are a few housekeeping rules to note. Feel free to ask any questions through the Zoom Q&A feature. Questions will be addressed at the end of every case, and there will be a feedback form at the end of the webinar to receive your certificate of participation. Also, a small reminder, there will be a Kahoot quiz at the end. Do stay tuned and stand a chance to win the grand prize. So now, let's welcome Associate Prof. Shamsuryani Mat Jamal, Head of Department of Emergency Medicine, University Kebangsaan Malaysia for the opening speech.
Okay, thank you very much to our both moderators, Ting and also Ming Hui. Good afternoon, everyone. I think it takes a lot of uh, motivation to be here at 3 o'clock on a Friday. The weekend is actually almost here, and also I think for our panelists this weekend is the Asian Summit, which is just around the corner in Kuala Lumpur itself. So I think I would like to congratulate everybody for being here today and welcome especially to our panelists to this webinar. It's really a pleasure for me, I would say, to actually sort of organize or actually to be having this seminar. Yeah? It's actually for the student, it's actually a very good chance to explore something that probably not so common in emergency medicine or anything that you've gone through your rotations throughout your fifth year. So I understand that our theme today is it relevant for medical students? It's actually a great question. I hope by the end of the session, I think you will agree that the answer is actually a solid yes. Okay, we are very lucky today to have with us three outstanding experts from across the region and beyond. Um, I think we have from Vietnam, Dr. Vanessa Nguyen, an attending physician and also toxicologist. From France, please welcome Colonel Dr. Oliver Un, a military field physician from the 1st Armed Forces Medical Center. And from Taiwan, Dr. Cheng Xuan Ho, Director of Emergency Surgery from Tri-Service General Hospital. To each of our panelists, thank you for joining us and for sharing your time and insights with our students. This is something that I think very good. This forum is very, very special because it is designed by the students for the students. And I think this is very good because it does not just show participants that you are becoming a participant, but it's actually showing that you're taking charge of your own learning itself. And I really hope that for the students, you will make the most of it. Very sincere thank you as well to Associate Professor Dr. Ahmad Khaldun, our program advisor, as well as our consultant in emergency medicine. His support, his energy, and his passion towards this, we really appreciate it. Thank you very much. So to all our students, the fifth year medical students, regardless whether you are interested in emergency medicine or you're interested in other field of medicine, I'm sure that learning or listening to this webinar or forum today, you're going to gain something out of it. Yeah. It might not be a topic that you thought that you would need, but trust me, I'm sure that it will be one topic that you'll be glad that you learned. So I hope that you guys will gain something from today, ask questions, uh, think critically, and enjoy the session. I think with that, thank you very much and happy weekend.
All right, thank you, Prof. Surya, for that encouraging speech. We will be sure to gain a lot from this webinar. So now let's get to know our panelists for this webinar. Today, we are fortunate to have with us three experts, as Prof. Surya said, beyond the region, and who will help us explore this theme through real clinical cases. So let me introduce Dr. Vanessa Nguyen, the attending physician and toxicologist, Doctor of Healthcare, General Clinic and Mental Clinic of Ho Chi Minh City, Vietnam. Secondly, we have Colonel Dr. Olivier Aung, from the military field physician from 1st Armed Forces Medical Center from Paris, France. And last but not least, we have Dr. Cheng Xuan Ho, the Director of Emergency Surgery Department of Emergency Medicine, Tri-Service General Hospital from Taipei, Taiwan. Welcome. Now, I believe we can officially dive into clinical toxinology. Can you please introduce to us what clinical toxinology is?
Okay, so clinical toxinology is a specialized area of clinical medicine focusing on the pathophysiology, diagnosis, treatment, and prevention of diseases caused by toxins. So what are toxins? Toxins are organic substances produced by living organisms as venom or poison, and they may harm the target organisms or even cause death. So snake bite might be the first thing that comes to our mind when we talk about toxinology, but it is more than just snakes. In fact, clinical toxinology encompasses a broad range of medical conditions resulting from envenomation by venomous terrestrial and marine organisms, as well as poisoning from ingestion of animal, plant, or fungus toxin. It is different from clinical toxicology, which focuses on synthetic chemical or toxic substances. So before this webinar, we have conducted a survey among 37 final year medical students in the current emergency medicine posting at UKM to assess their awareness as well as their confidence level in clinical toxinology. So based on the survey, more than half of the students are unsure or not aware about what clinical toxinology is all about. So furthermore, we can see that only a minority of the students in the current group or similarly in the previous group of students from episode 2 are confident in providing information to the public regarding clinical toxinology. So as we can see here, about 3/4 or even more of the students are not confident in providing information on the appropriate safety and health-seeking behavior regarding toxin injuries, such as informing the public that toxin-related injury is a medical emergency and the various emergency services and appropriate healthcare facilities that are available for toxin injury. Also, less than 20% of the students are confident in providing information on the role of remote envenomation consultancy service, also known as REX, which offers training and 24-hour on-call consultation service in the clinical management of toxin-related diseases to the healthcare professional in ASEAN since 2010. Again, majority of the students are not confident in sharing their knowledge on appropriate safety and health-seeking behavior, such as identify the common signs and symptoms of a toxin-related injury or disease, and the appropriate first aid measure for acute exposure of natural toxins, the various sources of natural toxins, as well as the emergency hotlines, guidelines, and resources for toxin-related disease, and the appropriate antivenoms that are available in Malaysia. So similarly, majority of the students are not confident in providing instruction or information for the toxin-related injuries. such as how to identify a potential tossing injury and administer the appropriate first aid, as well as the emergency procedures in cases of suspected tossing exposure. They are also not confident regarding the important history details that need to be obtained from following a tossing injury and where one should be transported after a tossing injury. So in summary, we can see that majority of the students are not confident in clinical toxinology, and hence it is our hope that this webinar will shed some light on this topic, which is relevant to the medical students as well as the healthcare professionals, as our country has diverse venomous or poisonous species in the forest, under the water, or even in our own house. So in this webinar, we are going to discuss a few clinical cases with our expert panelists. For your information, these are the actual clinical cases in Malaysia that were referred to REX in the past. So without further ado, let's begin our first case scenario, first case discussion involving a cute and innocent looking animal.
Okay, so back to you, Ming and Ting. Can we start the case, and we'll invite our panelists to comment on the case.
All right, thank you, Prof. Carl. So in our first case, as mentioned by Ting, we have a cute and innocent looking animal. So this is a case where a 25-year-old male with no known medical illness working as a zookeeper presented with angioedema and vomiting 1 hour after an alleged bite by a slow loris on his index finger while handling with bare hands. So on further history, the zookeeper had a history of bite by the same slow loris 2 weeks ago on his right thumb while putting it back into the cage with bare hands as well. Initially, he was asymptomatic with no allergic reactions. For that episode, he did self-irrigation with running water and applied iodine. He felt feverish for 2 to 3 days. However, he subsequently recovered spontaneously. So maybe I can ask a question to Dr. Vanessa. What do you think is happening in this case?
Olivier, would you like to maybe comment from your travels abroad? Have you encountered such a case?
No, I mean, this kind of mammal, I mean, it's the first time I see this kind of mammal. Usually I know like we have some mice, some mammal mice, some rodents that are venomous. But this case, I mean, I learned something today, so I'm quite happy to hear about it.
So do you think this is a venomous mammal?
Yes. Now I know. I looked for it yesterday. So yes, it's a venomous mammal.
Okay, so that could be a discussion about the status, whether it's venomous or not. Dr. Swanhu, have you had any experience for this case?
Oh, yeah, I didn't know what this animal is. I see this in the first time, and I Google whether he has the venom or not.
Okay, so maybe Dr. Vanessa is closer to home. I'm sure there is this mammal in Vietnam.
I'm not sure.
This is very good. So this is also a learning point, I think, for all our panelists as well. So this is not our first time having such a case in Malaysia. Partly because people, if you look at it, it looks very cute, big eyes, and people are keeping it as pets. However, this is a wild animal, and even though they look cute, they can actually cause injury by biting. So in this case, if you notice, this guy was bitten on the hand, I think, and this is not the first time he was bitten. So he was bitten 2 weeks prior, which was okay, but then he is bitten again this time. So initially there was no symptoms, but I think for this case, it will progress further, isn't it? Our moderator, you want to show us what happened to this patient?
Yeah, okay. So So on presentation at the ED, the patient's BP was 132/87. His pulse rate was 72 with oxygen saturation of 98% under room air. His temperature was 37. So as you can see from the picture, there was a small laceration wound over the index finger measuring about 1 cm with no exposed bone and muscle. Otherwise, the patient also had presence of periorbital swelling. So did some investigation. His VBG showed that his pH was 7.29. His bicarbonate was 22.1, lactate 3.8. So at that point, to resuscitate the patient, we given him fluid bolus. And on repeated VBG, his pH was 7.37, bicarbonate 22.1, and lactate was 1.3. So we given this patient anti-tetanus toxoid and adrenaline as well as hydrocortisone. We also given the patient cefuroxime and Flagyl. So we did some blood investigation. His full blood count showed that his white cell count was 6.27, hemoglobin was 17.7, platelet was 436. For his renal profile, his urea was 5.7, sodium 137, potassium 4.3, and creatinine was 131. In liver function test, his ALT was 21, ALP was 72, AST was 29, bilirubin was 12.7, and his creatine kinase was 238, and his C-reactive protein was 3.5. So at that point, we given the patient 2 pints of normal saline for hydration, and we continue the hydrocortisone.
Maybe you want to ask Matthew? Do you have any questions about the program? Yeah, is there anything that you want to ask about this case?
Excuse me, I want to ask. The patient just has the periorbital edema and no other anaphylactic reaction.
Yes, the patient only has periorbital edema with no other allergic reactions.
How about the vital signs?
His vital signs was rather stable.
Normal, right?
Yes.
Or you have only one reading here. Any subsequent readings of the vital?
No, this is so far what we've gotten. It is in. Okay. So
I mean, I just have a question. I mean, why did you throw the adrenaline? The guy was not in shock. But you directly throw adrenaline, hydrocortisone. I mean, directly the A-bomb. I mean, so is it like a protocol? It's a standardized protocol in Malaysia?
Good question. Why was patient given, or how is it given? Moderator, any news? Okay.
sorry, Prof, can you repeat the question, please?
Yeah, Olivia want to know that Olivia want to know why was patient given adrenaline hydrocort? Is there a protocol or what's the indication to be? Was it just because patient has periorbital edema?
Because I mean, even his blood pressure was fine. I mean, why directly throwing adrenaline?
I think they might be worried about allergic reaction in this patient.
But adrenaline, you have to throw it if you have like a shock signs, but there was nothing now.
Good point.
Adrenaline is not a Kit Kat or a Snickers or a Twix or a Mars. You know, it's can have side effects.
It's similar to a coffee drink. Yeah, so that's a very good point. I'm happy that somebody picked that up. So just because of periorbital edema, he was given adrenaline. And was it given IM or IV or
IV. It was given IV.
IV? Wow. Without any sign of shock in the vital sign, it was given IV immediately. Okay, anyway, maybe we can see what further explanation of the case. Things might reveal itself.
Okay.
And who managed this patient? I mean, did you manage the patient in a way? Who managed him?
Oh,
Was it you?
it's not managed by me. It was a clinical case referred to Rex.
Okay, so the suspect is not here then today for interrogation.
Whew, luckily. I'm here learning to become a safe doctor. Okay, so for the patient's progress, after management, he was clinically stable and well, and his angioedema has resolved. He was afebrile and his lungs were clear. His BP remains stable with 106/63, pulse rate 87, oxygen saturation was 99%, and his temperature was 37 dextrose 9.2. So the plan at that point was to continue hydrocortisone for 1 day and change to oral prednisolone and also cover with Puriton, and to continue IVD 2 pints for acute kidney injury, monitor for rebound allergy, as well as continue with the serial blood test.
Anybody wants to question this? Very blur now. I have so many questions. And let our panelists ask the question for clarification first.
May I have a question? When you see the patient at the ED and when the patient told you about the story when the animal attacked them or bite them or something like that. So I mean that at that time, did you search or to find something from the animal, I mean from the reference, because if sometimes when we, for example, in Vietnam, for example, in my case, if I see something very strange, new things, and I really don't know what is it and what is what the patient have maybe later. So do we need to search something and to know more about the animal, and then you will have the general picture that what you need to follow up the patient? I mean, at the first thing when you see the patient. Because, for example, when the patient show me the image of the animal, so I don't know this type of animal. So, of course, we can do everything to rescue the patient, for save the patient. But I mean that at that time, do you have any general idea in your mind that is what the next step you will do for the patient? I mean.
I think I will. I'm not an expert, but probably I will first stabilize the patient, especially in terms of making sure he is hemodynamically stable, and since we are not sure what is the animal, what is the animal involved. After he showed us the image of the animal, maybe we, other than asking the patient himself, who is a zookeeper, about what he knows, maybe he can also ask his employer about it. If we are not sure, we can also refer and talk to specialized toxinologist about this particular animal and know what to look out for and how to manage this patient.
Any general information from the zookeeper when he met you and he talk about the animal? And when you buy him, so because he is a zookeeper, so maybe he will know about the general information about the animal. They have a toxin in the body or something like that. If we buy, so it will be dangerous. So I mean that but for the zookeeper, maybe they can give the physician some information if for the first time the physician see the animal, because this is not popular outside. I see this is very, for example, to me, it's very strange animal. I haven't seen it, or I rarely seen it, so I don't know what it happened if by the patient. So I will ask the patient about in the general information about this kind of animal. Is it dangerous, or even the toxin or not, or just safe, or we just can follow up the patient normally, or if any infection in the wall, I don't know, but we can ask, right?
So, well, what is the story? Actually, the patient presents immediately having sign symptoms of angioedema.
Yes, the patient presented to
And
us.
it was second incident of a bite. The first one was okay. It's just this time he had symptoms.
Yeah, so the progress was during his first episode. He did like self-irrigation. He had fever for 2 to 3 days. However, he afterwards resolved, but no allergic reactions or stuff. And on this second episode of the bite, he presented with the angioedema.
Okay, so I agree that there is some reaction, and probably the first one that he encountered was sensitization. Maybe he had been keeping this animal and interacting with it for some time, because he's a zookeeper, right? The animal is in the zoo, and so what we know, could this animal be a venomous or not venomous, right? So it is not venomous animal or mammal. The only known venomous mammal is the platypus. We don't have the platypus in Malaysia. And the mechanism of a bite without having any what we call a venomous gland attaching to the teeth. It doesn't have fangs. One thing for sure. So the exposure that this patient received was from the saliva that the animal might have. So the feature is not a typical envenoming feature as well. Okay, so it's a more reactive hypersensitivity type. However, it didn't go into severe anaphylaxis or anaphylaxis because the BP was not affected. That's strange enough. But maybe the future bite might cause him to go to anaphylaxis because more exposure from the proteins saliva. The question is, do we know anything about what's in the saliva of this mammal? Yeah, they have done some studies. I've shared the article. You can have a look. And they are actually quite similar to the cat dander, cat what we call protein that can trigger allergic reaction. So that's what we have already, what we know so far, and we don't really classify them as a venomous animal. So in this case, it's a hypersensitivity reaction, and this is not, as I said, it's not the first time that we had encountered such a case. You mentioned here the patient had AKI, acute kidney injury. So the question is that because of hypersensitivity reaction, or is it because of the adrenaline? Dr. Oliver was saying, giving adrenaline and so on might cause secondary issues as well? Is that because of the vasoconstriction causing the AKI? Or is it because of the hypersensitivity reaction? Because the vital sign did not show any kind of hypovolemia, right? Could be an iatrogenic AKI.
Possibly. So actually, I mean, me myself would also like to ask if there are any improvements that we can do in the plan of management of this patient.
So the patient responded to the treatment, right? They gave some antihistamine and also steroids, and probably the adrenaline for the angioedema, but angioedema alone doesn't really need adrenaline, as Dr. Aun was saying, you know. So this is like over treatment with adrenaline. Anyway, what would you think if this patient was discharged, right? So what would your advice be for such a patient? He's still working in the zoo. Vanessa?
I think
Vanessa, do you want to have any advice for this patient? The patient is discharged well. No advice? All the best. Fan Ho? Dr. Cheng?
I have some opinion. Maybe the periorbital edema and the animal bite are two separate things. Maybe he was shocked bitten by this animal, so he used his hand to contact his eye or something else. Because if you diagnose this patient, he has the anaphylactic reaction, but he just has the periorbital edema, is non-reasonable. And but actually, in the clinical, we cannot have the immediate accurate diagnosis. So maybe you can try the first course of the antihistamine, the steroid, even the adrenaline, but continuing use, if I was the attending, I didn't give the continuous steroid use, because when the animal bite over the finger, the tendon injury or even the wound infection may be the first priority than the venous animal bite. Yeah. So if I in charge of this patient, I maybe give one dose of the antihistamine, not to continue the steroid use. Yes.
Okay. Olivia, any take from you?
Yeah, usually I would do the same, because the problem with the steroids is the rebound that will follow like a few days later. So usually I just put antihistaminics, and I would just have the wound care, antihistaminics, and just simple monitoring, you know. I would have dropped the adrenaline and the
Yeah, I mean,
cortisone.
that's why I said this
So
is like
basically,
an overkill of the treatment.
yeah, they want to kill the patient more than
Yeah. So and even the so-called periorbital edema, if you were thinking of hypersensitivity reaction, there are other things that also to look for. Any rashes, any urticaria, right? There's a document for that. That is the most common to go along with all the other hypersensitivity reaction for this patient or type 1. Okay, so what advice do we give for such patients? So he's been bitten now 2 times. So as I said before, most likely he's been sensitized more. So future bites or future contact with the animal will definitely cause a bit more severe presentation. It may not appear as anaphylaxis now, but in the future, future incident might actually go into hypersensitivity, severe hypersensitivity reaction. So we have to advise him to properly wear, protective
Glove.
PPE. Yeah, not just any glove, right? We had cases where they're wearing gloves, typical, thin cotton glove, and they still got bitten and caused a reaction as well. So it's not just any glove. So they have to have a very specialized glove to handle these animals. And also make sure that he probably follow up for possible allergic reaction testing. We can do that and to confirm. How do we confirm? So there are a few tests that we can ask the patient initially. We ask for the IgE and of course maybe IgG. IgE is for allergic reaction, and also if I'm not mistaken, thyronine or tyrosine, I can't remember. But anyway, there are things that we can actually use as a marker for if this is an allergic reaction. I'm not sure if we do it for this patient or not. Okay. Was such a test being done for this patient?
We have no further information on this case until afterwards.
Yeah, so this is unlikely and venoming. It's more of a hypersensitivity reaction, which if you're not aware of the animal and what we have already known about this animal's secretion, and we might think it is venomous, but we have to look at how it's being utilized by this animal, the secretion. It's meant for grooming and also to so-called like defense from his predator or so. Okay. There is actually a gland at the brachial gland that secretion that sort of like mixed with the saliva makes this more potent potent so-called allergic reaction that can happen. Okay. So anyway, interesting case. It's not every day we see cute animals causing problems to humans. Okay. All right. So maybe we move on. Any last question? Any question from the floor? Anybody like to ask question? Please ask in the Q&A box. We can address, the moderators can address to the panelists. So, okay. No question so far?
Yeah. I have a question. So
Yeah.
so this is not venomous then?
No, some people classify it as venomous, but it actually doesn't fit the category of being venomous anymore. It's more like a cat, also having all this potential allergic reaction if you are in contact with them. So even for snakes bite, if you are bitten or in contact with snakes, you are able to develop hypersensitivity reaction, even if it is not a venomous snake. So it's exposure to the allergen from this animal might trigger your body to respond, hypersensitivity reaction and so on. So it's a type 1. Okay, so you want to move on to the next case?
Yeah. All right.
Okay. So moving on, we have a 48 years old male with underlying prolapse intervertebral disc with no known drug or food allergy, and he lives alone. So he presented to a hospital in Sabah with shortness of breath, vomiting, and dizziness after consuming an unidentified species of fish bought from the local fish market, and he cooked the fish himself. Otherwise, there was no chest pain, no palpitation, and no diaphoresis. So to the panelists, may I ask what are the fish species that may cause this kind of presentation when being consumed?
For the history, it is not enough information for me to say anything about the fish.
Okay, what information would you like to know more?
Yeah, I would like to ask more the patient about more detail about what kind of fish or where he buy or where he bought it. and the color or the whole fish or what kind of part of the fish he ate or something like that with more detail. Or he describe about the fish. So let's see, we can show about information about the fish is the toxic or not.
Okay.
Yeah, and also if the patient, we also need to know if the patient eat the fresh fish or the or they put it in the freezer for a long time or something because the food will be not good. If you ate that, you also feel have a problem. Maybe not the venomous of the fish or the toxin of the fish, but just because it's the old one in the fish for a long time, it's also toxic to you. So this is
Okay.
if I meet the patient, I will do like that.
Okay. What else would you like to know, Swanho?
Yeah, I think maybe this is the histamine fish poison. Yeah, maybe he took a huge big fish and some his there are many histamine in the fish body, so maybe he took and then he has the toxic poison like the shortening of breath, vomiting, and the dizziness. And this experience also occur in Taiwan. Yeah.
You're talking about strombroid, possible strombroid poisoning, is it?
Yeah.
Olivia, you want to maybe any missing information you want to ask?
Yes. How many minutes? How many hours after eating? Because it can be, I don't know if it can be like 6 hours after. It can have, maybe it's not the fish, maybe he has other diseases. It's like we need to know like how many minutes, how many hours did he start presenting these symptoms?
So yeah, that's correct. How long did the symptoms? When did the symptoms started after eating? But I think there are more things that can be asked in the history itself, even about the fish. Which part of the fish being eaten? Is it just the flesh or the whole fish, or including any organs of the fish that have been eaten? And before having the shortness of breath, is there any other features that might happen to the patient? If you are talking about histamine, then you might be looking for rashes, right?
Skin, yeah.
Yeah. So, but it wasn't asked or wasn't mentioned here. The shortness of breath. So before shortness of breath, is there could be any sign of what we call paralysis? For example, you have perioral numbness or any difficulty in swallowing before going to shortness of breath. So it's kind of a progression of neurological feature. Dizziness, any palpitation, any difficulty breathing, which patient has shortness of breath. So about the fish itself, the patient doesn't know the species. So I would ask where did patient, as Vanessa was saying, where did the patient get the fish from? How did the patient prepare the fish before cooking? Anybody else eating? All right. Okay. So any other information the moderators can provide us based on this?
Okay. So further history is
The first
definitely
time,
sorry.
this is the first time he ate this kind of fish, or he ate many times already, but this time he had a problem.
Yeah. Anything different this time in eating? Is it the same as before?
The first time?
Yeah.
Okay, so upon further history, so the patient mentioned that the fish, he couldn't tell the exact species of the fish. He told the doctors that the fish he consumed was called ikan buntal, which is a very broad term used by the local people that can be referring to porcupine fish or puffer fish, even though they are from different families. So for information, both porcupine fish and puffer fish look very similar in terms of their appearance and are commonly sold in the fish markets in Sabah. And puffer fish is particularly infamous for their deadly toxin known as the tetrodotoxin. So unfortunately, the further details about the exact type of fish, the nature of preparation, and the amount of fish, as well as the parts of the fish consumed, were unable to be obtained from the patient at presentation, as he was quite unstable at that time. So upon arrival at ED, emergency department, his Glasgow Coma scale was E3, V5, and M6, and his pupils were reactive. He has good perfusion, as well as slurred speech. Vital signs at that time, his blood pressure was 199 over 111 millimeter mercury, pulse rate 91 beats per minute, and respiratory rate 19 breaths per minute. Blood glucose was 8.0. So on respiratory examination, the lungs were clear, and on auscultation of the heart, there was dual rhythm with no murmur, and per abdomen it was soft and non-tender. So neurological examination revealed that there was generalized hypotonia with power 3/5 over the left side and 2/5 over the right upper and lower limbs. And there was also hyporeflexia with Babinski upgoing over the right side and downgoing over the left side. So at that time, stroke alert was activated by the doctor in view of patients having signs of stroke. However, the CT and CT angiography of the brain were normal with no intracranial bleed. So upon returning from CT brain, the patient desaturated with SpO2 60% under room air, and there is asystole. Thankfully, thankfully, return of spontaneous circulation was obtained, and the patient became hemodynamically stable after the resuscitation. And after 7 hours in the emergency department, the patient desaturated again with increasing oxygen requirement, and he was subsequently intubated and sedated. Pupils were dilated 5 millimeter, and there is still good perfusion, and the BP was 153 over 97 millimeter mercury, and the heart rate at that time was 97 beats per minute. Oxygen saturation was 89% on fraction of inspired oxygen 1.0, and became 100% upon manual bagging. So on examination, there were generalized crepitation in the lungs with copious amount of frothy pink secretion upon suction. And on auscultation of the heart, there was dual rhythm with no murmur, and otherwise there was no pededema. So the doctors there did a bedside transesophageal echocardiogram, which shows good contractility with no right ventricular strength, and there was no pericardial effusion. However, there is generalized B-line seen in the lungs with no pleural effusion. So next. So after regular suctioning, and the patient was put on higher ventilator setting, so his SpO2 improved to 98%, and the BP remained hypertensive, and the pulse rate was 89 beats per minute. And later they did a ECG, which shows a sinus tachycardia. And blood investigation like full blood count, renal profile, liver function tests, and arterial blood gas were done, and these were the result. Chest X-ray was also done, which revealed features of acute pulmonary edema. So to the panelists, may I ask, based on the limited info here, so what is your working diagnosis at this point of time, and how would you further manage this case? Or how would you have done differently?
I think this maybe like the TTX poisoning caused by the pufferfish. But I cannot see the timeline because the TTX poison may be very rapid quickly, and maybe when the patient took the fish about 30 minutes, and he may feel some tingling over his mouth, and then he has some gastrointestinal tract symptom, and then he will suffer from the respiratory arrest because he cannot respiratory. Yeah, but I have some confusion about the acute pulmonary edema because this patient may be he was paralyzed by the TTX, but how did he develop the acute pulmonary edema is my confused. Yeah.
I just want to make a comment as well. I mean, at this point, we can rule out the an histaminic release like scombrotoxis. But the same thing, like for TTX, he didn't present any perioral signs or so. It's a bit confusing, and especially as my Taiwanese colleague said regarding the lung injury. I mean, it's not so logical. So
Yeah, it's a bit confusing in the presentation. Some of it sort of like doesn't make sense. So we don't know really why the patient present with APO, probably because the patient collapsed, and that kind of have a secondary effect. Patient was on CPR, right? They did CPR on this patient.
Yeah, they did a CPR after the patient returned from CT break.
Yeah. So if the patient, to me, if the patient had a collapse after TTX, it's not because of the heart failure, but because of hypoxia. So most likely this patient was missed because the patient went to CT scan, if I'm not mistaken, right? And then they identified patient had hypoxia and collapse. So most likely it was not properly monitored when they did a CT scan. So what was the what was the indication for CT scan for this patient?
Because at that time they suspected the patient to have a stroke. So
yeah,
like
but then, but it's not the stroke, but it's because of the paralysis from tetrodotoxin. So it's not centrally issue. It's a paralytic issue, right? So all these things come into play when you are managing a patient. I think if you are not aware of certain things like hyporeflexia and then hyperreflexia, that's very strange. Patient is paralysis, but hyperreflexia, this kind of contradicting. So probably in the documentation was not already showing errors in actually assessment of this patient. So again, suboptimal in the clinical how patient was examined because it's contradicting itself. Yeah. So anyway, patient, what happened after patient? Or Olivia, you want to comment again about this?
yes, I have a comment. Did they dose the pro-BNP, the anti-pro-BNPs to see the heart? How was the heart? The anti-pro-BNPs, were they dosed in his case?
I don't think.
Try to explain.
I don't think they did.
From our record, it's not done.
Yeah. So
because if the anti-pro-BNP were normal, so you can rule out the cardiogenic cause. So
yeah. Well, tetrodotoxin can actually affect the heart, but it's actually at a very severe form of grade 4 of the tetrodotoxin poisoning, right? So that can actually affect the heart, but that's very, very high dose of tetrodotoxin, which may cause failure and indirectly will then hit the lung, cause pulmonary edema. But I think the reason why patient collapses is because of hypoxia from paralysis, and we don't know the time span when the patient was in hypoxia because he was in the CT scan and nobody was monitoring, right? So that's the problem. Yeah. So what happened after this patient intubated? ventilated under higher setting? Any progress?
The patient was intubated. Yeah. However, we do not have the further progress for this patient for the clinical part. And so
Yeah.
indeed, yeah.
So how do we make so this is the food that the patient cooked?
Yeah. Yeah. So in the same evening, the patient's brother managed to break into his house to retrieve the fish. So this was how the fish looked like in the patients, and according to the brother, it was very, very smelly at that time. And the fish was then brought to the hospital, and the staff attempted to restore the appearance of the fish as much as possible, as shown here.
Like a jigsaw puzzle.
Yeah. So next. So as we can see here, the fish sample here could resemble both porcupine or the more toxic pufferfish, which has similar black dots on the tails. And the medical team at that time were in a dilemma on whether this is a pufferfish or this is a porcupine fish, and were asking if there is any way to how to say, to confirm the species. Yeah. So to the panelists, do you have any thought on this?
So can Taiwan Poison Center identify species like this, or you send for specimen to the lab?
Yeah,
We
and
did
last year
forensic.
last year we sent the similar fish, part of fish sent to the poison control center, the Dr. Yang, and he helped us to identify the fish. They identify the fish by the appearance identified. Yeah, that's the expert. He can see the residue of the fish, and he can identify the fish. And then they check the cytochrome B, the genome analysis from the PCR, and they detect that case he eat the pufferfish. Yeah, but in Taiwan we have the educate about we want the people did not to take any like the pufferfish or the pumpkin fish. Yeah, in Taiwan we almost most of people think these fish are venomous or poisons. Yeah.
Okay, so what else can we do? Can we send for level of tetrodotoxin in patient or from sample?
Oh yeah. Also we send the urine and the blood from the patient to detect the TTX, but we detect only the analog of the TTX. Like means the 11 non-teratotoxin. Yeah. The lab say we provide the clinical sample contain less amount of TTX, so they cannot show the exact value of the TTX. Yes. So in Taiwan, we can send the fish sample, also the clinical patient sample to identify the pufferfish. Yes.
Okay, so what else can we do in terms of public health? What can we alert somebody to maybe investigate the place where the patient bought this from the market? So what is the practice in Vietnam if you have, let's say, some kind of this poisoning? Are you going to make a public surveillance? Are you going to alert the public health?
Yeah, in Vietnam, sometimes but rarely. Yeah, but we still have a kind of this fish, but rarely. But we still have several cases. Another time, just supportive treatment, and we don't have any test to identify the TTX, but we just based on the clinical sign symptom of the patient and ask them about more detail of they can describe the fish, because in Vietnam most of these cases because the patient they will live near the seaside, yeah, near the sea. So let's say they are like fishermen. So and they fish it and they think that they can eat it. Yeah, usually in our case it's like that. So let's see, they can describe about detail the fish to the physician, and then and also based on the same symptom, so we can make a diagnosis, but we don't have any tests to confirm or identify the TTX. Just that. And for a lot of public health, it depends on the hospital if they like to alert to the public health. So the journalists will write something of information about that case to alert the public health. But until now, it's not popular for a lot of public health. But I mean that for people, they know that this is a dangerous when you eat the puffer fish.
Okay, so Olivier, what do you think in terms of management?
Yeah, I was looking for the microphone. So in this case, we need to directly head for the fish market, and the seller is going to need to reply to some answer some questions, and
Yeah.
and probably maybe going to do some jail time as well. So
yeah, maybe
we have to quickly try to inform the people who bought fish the same day or the same kind of fish and alert them before they start cooking and have other casing in the city.
Yeah, because that's very important. This is just one case. Actually, there's two more cases where the whole family ate the food. It's just one guy. So there's other cases that people bought from the same market, the fish being sold. So how do we notify the public not to buy or sell this fish? So it's important for us to alert our what we call public health and community health. So they will do a surveillance all these markets that sell. And the funny thing is that some of them sold this fish already processed. They already cleaned the fish. So it's difficult to identify, but they sell the meat and also the internal organ. So if you understand some of these puffer fish, the most potent component toxins are located in the internal organs, which are in the ovaries, in the liver, in the gut. So some of them sell the fish flesh with the liver. So most likely this patient ate the liver, and you can see just now in the pot, you can see still a lot of the flesh available. So we just had one case 2 weeks ago. This case was in Sabah, in East Malaysia. So about 2 weeks ago, we had one case in Negeri Sembilan, which was not reported by the media. And this gentleman ate the fish for the second time. The first time he ate only the flesh, and he was okay. Then the second time he caught the fish, he ate the flesh and the internal organ as well, so the liver, and he died. So this was the death that we had. For this case, I'm not sure whether the patient died or not. Is there any follow-up from this patient?
There were no further update in the
I think this patient survived. Maybe I think it was activated and went home. So tetrodotoxin, there is no antidote for the poisoning. So we have to the standard management is to manage the airway. Definitely will be on ventilation. So as you understand, in the toxinologists, the toxin itself, the tetrodotoxin, is not is water soluble. It's not fat soluble. So there's nothing that we can use, for example, intralipid to absorb these toxins from the body. So it just takes time for the toxins to be washed out. So luckily, this patient doesn't have any acute kidney injury. So that will expedite the what you call excretion of the tetrodotoxin from the body. And it's about it's only time will tell how long the patient will need to be ventilated. So eventually it will be recovered if the kidney can wash out the toxin. Okay. So this case survived. We had a few cases which in the past 2 years caused death, and there was elderly cases. So this guy is quite young, isn't it? Yeah. Okay.
So may I ask, is there any first aid measure that people can take before they reach the hospital?
After eating pufferfish.
Yeah.
Okay. Maybe the panelists to answer first.
I think he can bring the fish to the hospital, except that he cannot do anything. Yeah, when he bring this fish to the hospital, he can help doctor to identify the fish,
Okay.
and
But
this
first
is
aid,
very important.
to the patient itself. What can you do? I've eaten pufferfish now. I have symptoms. What can I do? As the first aid.
Just, if you have symptoms, first prevention, you have to stop other people from your own family to eat the same dish.
Okay. For yourself?
Yeah, and for myself, I'm just gonna go to the hospital with someone and tell to someone that takes care of me and call the emergency as fast as possible and bring me to the hospital so I can get intubation.
And can you induce vomiting to release all what's in the body, what you have eaten? Is that a good advice?
No, because you're gonna worsen the problem. So I think
And
just head to the
possible of
hospital.
aspiration as well, right?
So just head to the hospital and stop other people eating the fish, and go and call the fisherman who sold the fish in the fish market.
So this is another danger of getting fish from people who we are not familiar with, and they just give you the fish to eat. We had cases as well where they don't give the whole fish; they just give the internal organ, the liver, to other people to eat and cook. And we question whether this is actually a criminal act, causing with their argument or so. For example, they just give. So this is a danger of this fish. People can use it for criminal usage, poisoning you. And that's why it's very, very strict in Japan of how this fish is being handled. And you have to have a proper licensing. Nobody actually can just simply catch and eat the fish on your own. You have to have, proper training to even clean the fish before cooking, right? Olivier, in Japan? Tetrodotoxin is very, very strict.
Yeah, in Japan, the legislation varies in each prefecture.
Yeah.
So it depends. Some prefecture, the cooks, they have to go through a training, and they have to renew their training every year. Some every 5 years, some every 10 years, some never. So it's depends on the prefecture. But yeah, the problem is if someone catches you and you don't have the license, you close your shop and you go to jail.
Yeah. Okay, so just to bear in mind as well, not all pufferfish has the same toxin in every part of the body. Some species will have different parts have more toxins in the body, for example, in the gonads and the liver, but not in the flesh. So you can eat the flesh, but not the internal organs. Some contains also in the flesh, and therefore the whole fish cannot be eaten. So you need to understand what species. And you have to also understand that this fish produces, how is this fish producing tetrodotoxin? It's not like it's indigenously produced in the specialized gland. No, it's actually a commensal bacteria in the gut of the fish. So this bacteria produce the antivenom, produce the toxin, and it's stored around the body. Okay. So if and this is needing the fish to be in the wild caught. So in Japan also there are restaurants selling puffer fish as to the general public, but the fish that they use to serve the people to eat in their restaurants are actually cultivated puffer fish. It means it's not it's in the tank. It's not in the wild. Okay, so since it's controlled, so the amount of tetrodotoxin is either very low and there's no contact with the bacteria. So the fish is not doesn't contain tetrodotoxin. Okay, so this is very interesting. Is it a farm fish or is it a wild caught fish? Okay, so in this case, this guy got the fish from the market, which is wild caught. So most likely the fish has already the bacteria in the gut that produces tetrodotoxin. Okay, so this is something that we have to understand. If you want to make a legislation and so on, this will come into play. Okay, all right. Any questions? Any question from the floor? No. I think there's one in the chat. Yes, in Malaysia we have to notify. Like any other poisoning, has to be notified, and they will send a team for surveillance and also sampling for testing of the sample. So they will send to the lab for testing for tetrodotoxin, how high or level. So this is what happened with the previous cases. The fish was already processed. It doesn't look like a puffer fish, but when they sent to the lab, they found the level of tetrodotoxin in the sample very, very high. Okay, even from the flesh. So the fish could be contaminated with the tetrodotoxin from other parts of the organ during processing. Okay, right.
So I think that's all for this case. I think we can move on to the next case, which will be presented by Miley.
Okay, so moving on to case 3. So we have a 69-year-old female with underlying hypertension presented to ED at a district hospital in Pahang 2 hours after an alleged snake bite over the dorsum of her right hand while lying on the bed to sleep. She complained a pain score of 6 out of 10. She has no shortness of breath, palpitations, or gastrointestinal losses. So when the bite happened, the patient screamed and her neighbor came over to kill the snake. They were unsure of the snake. However, on further history and also image provided, the snake was in black color with yellow stripes and has a black tail. It just suddenly jumped over the patient when the patient was lying in the bed from the roof and bit the patient. So maybe to the panelists, based on the appearance of the snake and the descriptions, are there any species that comes to mind?
The fungus maybe is the first impression because when the patient bitten by the fungus, he feels severe pain, and fungus appearance also like this photo. And maybe if I was the attender, I will pay more attention about this patient, about whether he will develop the respiratory failure or severe pain. Yeah. When patient bitten by the fungus, the severe pain, hyponatremia, and the respiratory failure is the most concern. Yes.
Okay, so when the patient was presented to the ED, he was alert with good pulse volume, warm peripheries, and the capillary refill time was less than 2 seconds. His BP was rather high, 165/75. His pulse rate was 60. Her respiratory rate was 20, and her oxygen saturation was 98 under room air. And she complained of severe pain of 6 out of 10. And for respiratory, as mentioned by Dr. Ho just now, examination shows that her lungs were clear. And cardiovascular examination showed dual rhythm, no murmur. And abdomen was soft and non-tender, and there were no palpable lymph nodes. So for local examination of the injury itself, as seen in the picture, not sure if you guys can see the 2 fang marks over the dorsum of the right hand, which is swollen and erythematous around the fang mark. So there were dermal necrosis seen, and however, there were no active bleeding. Distal pulses were palpable. So may I ask to the panelists, at this point, would the patient be considered to be given antivenom, or is there any specific signs that we should look out for to decide whether we should give the patient antivenom? Maybe Dr. Oliver, do you have any thoughts on this?
Like for the first symptoms, I mean, I'm not specialized in Asian snakes, but when you see the first symptoms, you can suspect from a viper from the first symptoms. But did you do like blood investigation about his platelets or coagulation time? Do you have any information?
Yes. Maybe I can proceed with the investigation first. So the initial management at the ED, the patient was given IV tramadol 50 mg stat and IV Maxolon 10 mg stat. So at that point, her pain score improved from 6 to 2. And we also did some investigations. His full blood count showed a total white cell of 9, hemoglobin 12, platelet was 208. His renal profile showed that his urea was 5, sodium 140, potassium was 4, creatinine was 146. Liver function test, TP was 76.6, albumin was 45, GLB was 32, bilirubin was 8.8, ALT was 12, and AST was 18, and ALP was 82. Coagulation profile, his platelet was 12.2, INR was 1.2, and APTT was 33. Creatine kinase was 89, and LDH was 224. At this juncture, does any panelist have any thoughts or any management plan for this patient?
Actually, this is the initial result, right? This is the initial one?
Yeah.
Yeah, maybe there's nothing much we can comment on from the initial. It's just a baseline. So do you have a serial result? Is there any progression of the patient?
No. This is the information that we have gotten from the case. So we don't have
result. There's no subsequent result. There's no table. Typically, we do every 6 hours.
Yeah. But from the case file that we've gotten, we did not have a serial results of the investigation, unfortunately.
Yeah. So yeah, for the moment, I would rank him like a grade 1 envenoming for the moment, and I would just monitor him. I'm not gonna throw my anti-venom vials for the moment. I'm just gonna wait. And
there's no real indication for anti-venom at this stage, right? Taho, what do you think?
I'm curious about the dermal necrosis. I see you present in the physical examination. The dermal necrosis is in the beginning or after beating for several hours.
Is there a dermal necrosis in the picture?
From this picture, I didn't see any dermal necrosis.
I can't really see it as well. So
maybe another picture.
Maybe very, very small. Is there a follow-up progress of this patient?
No, we don't. Unfortunately, we don't have further information on the progress.
Okay.
So at that point, the plan for this patient was just to admit for observation, do hourly rate of proximal progression, 4 hourly vital signs, giving her adequate analgesia, watch out for local or systemic envenoming symptoms, repeat the blood investigations, and serial clinical progress observation chart, as well as serial blood results, as stated by the panelists just now as well.
Any swelling?
Any swelling?
Yeah.
Uh,
But the picture doesn't show much swelling, I think.
in the local examination, it also showed that it is stated that there is swelling.
Yeah, but
and
that,
also erythema.
okay. So can we see what's the progress? Anything else you want to give us?
No, this is actually the end of the case that we received.
So, okay.
I just have a comment. You know, here so you repeat full blood count, creatine kinase is daily. And what about the kidney function as well? Don't you monitor it daily? Or a dipstick in the urines as well to look for kidney injury, especially when you're in Asia?
Okay. So we practice in Malaysia based on, in this case, a syndromic approach, right? So we monitor quite regularly every hour in the physical progression, and then for the lab, we do every 6 hours. If there is a kind of trending to certain, for example, platelet count or coagulopathy, INR rising, then that may suggest pit viper envenoming. But that has to tailor with the physical findings. If a pit viper for Malaysian scenario, the species that we have, you will get a progressive swelling. Means that every hour it keeps on progressing proximally, and we have developed this technique with this protocol with Taiwan, with Fanho. We call it the pulse protocol. So we are using it now to monitor the progress, not just simply with physical examination by your hand and by your eye, but also with ultrasound. So we are now using this to more accurately so-called measure the progress, the so-called trending of the rate of proximal progression. First is the location of where is the edema, where is the margin, and then we monitor hourly to see the trending in the progress. And also, if it's worse, then we use the draft, meaning we look at the retrograde flow of the artery in that particular limb. We can only do in the limbs. We cannot do it if it's beaten in the body or other parts. There's nowhere to do draft. So only if it's in the limbs that we can do draft. So these three components is what we call as pulse protocol. So Dr. Swanho is the one put this all together, and we are using now in our sling bite management of patients. So can we look at the first page and the scenario of this patient? Is it really patient bitten by a snake or not? Yes. So that's the actual picture.
Yes, that's the actual picture taken by the neighbor, the snake killed by the neighbors.
Can you zoom in and make it bigger or not? Okay. It's very bad, but okay. Anybody want to identify? Is this a venomous snake, not venomous snake? Okay. Okay.
I mean, based on the symptoms, we can say there was some envenoming, so it's a venomous
but
one.
we also have some species which of pit viper, for example, which have venom, but it doesn't cause systemic envenoming, as we would expect from pit viper causing coagulopathy, right? But for example, Tropidolaemus regulari and Tropidolaemus subannulatus, they don't cause coagulopathy in our patient. they have venom. It can cause physical injury, swelling, maybe a bit, but not severely progressing. And patients go home without needing any antivenom. There's no antivenom for those two species anyway. Okay, so it's very difficult to identify this case. The picture taken is very bad. So what we need to do, we have to monitor the patient serially. As I said just now, we start the post-protocol, the blood investigation. If after 24 hours or 48 hours, it remains normal, then we can consider just discharge. Question is, what is our diagnosis? How would you diagnose this case? What would you like to put as the diagnosis? Anybody? Can we see
in this case, I think this case is very difficult because he has both caricature of the P. viper and the Elepidi. Like the dermal necrosis may be belong to the Elepidi, and this appearance like the bone grass. Yeah, but he has significant fat marker. And the rapid swelling progress. These are all caricature of the P. vipers. So this case is very difficult. It contains both kinds of species.
Yeah. So the question is whether this is actually dermal necrosis or not. So the thing that many people are also confused with is the mechanical injury causes ecchymosis. So here you can see that's actually possible. It's just a mechanical injury with ecchymosis, not dermal necrosis that we typically find following a cobra bite or Naja species. Yeah. So I think and there's no severe swelling as well. If there is a dermal necrosis from Naja, you will see very significant swelling as well, right, Panho, in Taiwan as well. So we get some swelling progressing proximally, but not in this case. Yeah. Anyway, so what do you think, Vanessa? What you want to do? Observe this patient? Discharge home?
No, I have no idea because I don't know what kind of the snack in the picture. So
Yeah.
we just divide in the two situations and observe the patient.
Okay.
But until now, I mean, for the all the information here, so I think just observation.
Yeah. So I think continue observation and do the serial observation. And the patient is well within 24 hours. No increase or worsening of symptoms. Swelling is not progressing. Blood results are all normal. I mean, 3 blood results. So I would discharge the patient after the 24 hours. So the diagnosis is still considered unidentified. If you are not confident in identifying that species just now, I would put it as unidentified snake bite. Unless somebody can actually bring the specimen and also better picture of the specimen, we can identify that. Okay, so at the moment we just manage as Dr. Aung said, as Oliver said, it's a syndromic approach. So this is one of the situations that may benefit the patient for short observation. Okay. So any last words before we move on to the next activity?
Yeah, so Cal, I was saying about the kidney markers. So you don't dose them, right, in Malaysia? You don't check for you don't do a dip or
Yeah, so in Malaysia, our species do not have issues with things that cause kidney failure. Like for example, the Russell's viper. We don't have Russell's viper in Malaysia. And the one that can actually indirectly cause renal injury from myoglobinuria, which is bitten by sea snake. So those are the situations where we may want to look at renal function and also the color of the urine. If there is a situation where suggestive of sea snake, fine. Okay, but for the land snake, we so far have no species that directly with the venom directly attacking kidney. So like cytotoxicity or what you call kidney injury directly to the renal toxicity. So thank God. So that makes us a bit easier in the management. Not that too difficult just from the observation of the syndromic approach for our situation. I know, let's say, for example, in India or in Sri Lanka or in Thailand or even some parts of Indonesia that may have issues, right? Some venom cause direct renal injury. Yes. Okay. Anybody else would like to have last words before we move on for the cases? No? Okay. Right.
Okay, so I think that's the end of the case tree. I'll pass it over to. So since we are short of time, so I don't think we are able to discuss case 4 and 5. So now, thank you to our panelists, Dr. Vanessa, Dr. Olivia, and Dr. Ho, as well as our Prof. Khaldun for sharing your expert opinions in the clinical management of toxin-related diseases during our case discussions just now. So now probably I can pass it to Prof. Khaldun to give our students some quizzes.
JK also, yeah, more than welcome to join. And do we have a present for this? Do we have a gift? What will be the champion?
Yes, we have one for the champion.
Yeah. What will the champion get?
A book of snacks.
Okay.
Can I get a discount on puff?
You will get this book, Land Snake or Medical Significant book. Okay, this is the 3rd edition. So the champion will get this book. The winner, please, the champion, please give your details to our secretariat at the end. Who is the champion? Number 3, number 2, and the champion is.
So, thank you, Prof, for the quiz, and congratulations to the winners. Now let's welcome our head of module, for the emergency medicine posting, Dr. Irene, to deliver her closing speech.
Good afternoon, everyone. Thank you for giving me the opportunity to join your forum for today. It's a very interesting forum. I want to say thank you to Prof. Khaldun for being the supervisor for the medical students. And I want to say thank you so much to the medical students for your dedication, especially to organize this session on clinical toxinology. And I would also like to say thank you to our international panelists. All of you are so kind to share your time, your knowledge, and your experience with us. Your presence in this forum is very much appreciated. So toxicology, as we have learned, is not just an academic topic. It's a critical component of emergency medicine. So the knowledge that we gain today will help us to be ready in managing patients in toxin-related injuries. So I hope the students here learn to appreciate the importance of this field in clinical practice. So that is all from me. Thank you so much for this opportunity, for allowing me to join you all today. Thank you.
Okay, thank you, Dr. Irene, for the wonderful closing speech. Before we end our webinar, can we invite all the panelists and advisors to turn on your camera for a quick group photography session? Okay, so we have come to the end of our webinar today. To all participants, please scan this QR code to fill in the feedback form to receive your e-certificate. And also, CBT 1 point will be awarded to the Malaysian doctors attending this webinar after filling in the feedback form. So please ensure that you complete the form with your full details to receive your points. And you may also click on the link in the chat box to fill in the form. Yeah. So once again, we thank all of you for joining us today, and we hope that you have learned something about clinical toxinology from this webinar. So see you in the next episode of Clinical Toxinology. Is it relevant for medical students? Bye bye.